I just need to know where you got that chair. I mean, like, compared to this, compared to this shit, your chair is so comfortable.
I don't know, bro. Someone just ordered it for me. I'm sure I asked for it. I was like, I need a
I
chair.
mean, I need more details. I need to know who this someone was. I need to know where they ordered it from. And I mean, obviously, it's like it's going to be super high class. So I need to know how much of a bank loan I need to take to buy that chair because, Jesus Christ.
Yeah, I mean, you'll have to save up some. The orthopedic salary might not be able to
No
make up for
kidding. I
this
mean, I'm
chair.
over here sitting in like this proletariat chair. You got your bourgeoisie little throne over there. Oh my
Yeah,
gosh.
I
The
mean,
only
like,
reason we
when
even
you when
figured out that Humayun's chair is so awesome, he's never let me sit in his chair before, by the way, is we just switched spots for a second because my video was lagging, so we needed to go and check the other one. And I sat in his chair just to check, and I just forgot we were even doing a podcast. I was like, dude, this chair is just like remarkable. Oh my God. I might take it
yeah,
home.
yeah, one day, bro, one
Oh
day,
man, it's a nice
one
chair,
day
but
when
anyways,
uh, one day when Baylor is able to, make some money off of Bentob,
yeah, no kidding, right?
they'll get you the chair. But yeah, I
Yeah,
mean, I have to sit here and do notes all day, so something has to be comfortable, right?
there you go. Yeah, we'll get you a standing desk, and I'll take your chair,
Yeah, I'll get one of
dude.
those
People do
treadmill.
that. I remember, dude, in med school we had like a bunch of those treadmill desks. I mean, I
Yeah,
think we had like four of them in a row, and kids would just like walk on the treadmill while reading a book. It was like a thing back. I think it was like a fad because I haven't really seen very many people doing like treadmill desks recently.
yeah, I have it at home.
Do you really?
Yeah, Mariam randomly just bought it. She was like, she got excited and she
Does
was
she use
working
it,
from
or do
home.
you use it, or it just sits there?
Right now, it's just sitting there. No one's using it.
It sounds about right.
Yeah, we were like, oh yeah, it's a walking pad, and it comes with the desk, and then you can just the desk can go all the way up, and you can just walk and do your work. But how do you do like medical notes and read echoes while walking? I don't know.
I don't know either, man. I mean, maybe if you're dictating.
Yeah, dictating or something. But I can't think, man. I can't. I just have to. I can't do stuff while walking. I don't know. I don't know
Oh,
how people
really?
do that. I can maybe study or think or like think about ideas or reflect on stuff while walking, but not like do productive work.
Yeah, I guess that's true. I mean, I guess if the work is also dependent on like a computer, it'd be weird to walk and try to input information into a device. Um,
I
yeah,
do
but
like
I'll like walk and read every now and then. Like if you're holding a book, like sometimes I don't know, it's just annoying to sit for a long time. I'll like walk like lazily in the house and read.
I can't do that. I
Yeah.
have to sit there or lay there and be still. But I can if I'm on a phone call, I can't sit still.
But yeah, I'm a walker when I'm a talker on the
Yeah,
phone. I
yeah,
can't
for
sit down
sure.
and talk on the phone. It's weird, dude.
Yeah, it's weird. Like people who just sit there and talk, that's something weird. So
Yeah.
it's weird. I'll if I'm talking on the phone, and even though I'm not on the phone as much, I mean, very few times I'm
Right.
on the phone. But if I'm on the phone, I'm just like walking around,
Yeah,
or I'm
same.
driving. Something has to be happening if I'm on the phone.
Yeah, it
Yeah,
just makes I don't know, it just makes a more active process.
yeah. The things you do to kind of distract your mind. Yeah,
Yeah, man, and that kind of brings us to the first topic for today, like a theme, a loose theme of mindfulness, I guess, but a topic on how to distract yourself or maybe how to be more mindful of stuff is, when we talk, which is common in medicine, talking about pain, a patient's perception of pain, and what are some methods to ameliorate that, to decrease their perception of pain and the pain scores on these patient-rated exams. One of the topics we came across that I thought was interesting was the distinction and the comparison of prayer versus music and how each of them can decrease a patient's pain perception. I thought that was a pretty interesting study, especially how especially the study design. Like the catchphrase. Oh my gosh, prayer versus music. Which one is better to help patients who are having pain? That's very broad, and honestly, the way the studies are designed, they're not really going to be able to compare overall prayer versus music. There's so many different kinds of prayer and so many different kinds of music. You know what I mean?
yeah. I mean, the whole reason we started this podcast was we would see these random headlines, right? There's all these headlines, and they catch news, five crazy symptoms that all doctors missed, and then
Yeah.
when you read, and then a computer solved it. you
Right.
see these headlines, and then you're like, what the hell that is? And most people never really read into it or read the article. They look at the first paragraph, kind of see, oh yeah, doctors missed these diagnoses and AI found it, and but when you read deeper into something and look more into it, you find the faults and why those headlines were mostly for attention grabbing or
Yeah,
clickbait,
it's
right?
just clickbait, right?
Clickbait. And then we saw this topic that music versus prayer, which seems very interesting. The study is um, in May or June of 2026. It was an open label randomized trial at one site where they enrolled 180 adults into the study, and 90 of them randomly got a music arm, and 90 of them were assigned to prayer arm. The prayer was with a person, kind of it was described as a proximal intercessory prayer for 5 minutes versus 5 minutes of recorded music, not an actual person playing the music or doing music therapy, but recorded music that they're listening to. And that showed that people who underwent prayer had much lower pain scores after up to 6 weeks, and a lower level of anxiety as well. So patients who reported pain initially and anxiety initially, people who used prayer had a much lower pain scale and much lower anxiety level in 6 weeks, or within up to 6 weeks, which is
Compared to the recorded music
compared to the
listening
recorded
group.
music line, which is an interesting idea, interesting thought, that prayer. But there's a lot more into it, that when you look into the study and see what happened and what it looked at and what it considered prayer, what it considered music. It's a very interesting idea.
Yeah, even like so the to break it down a little bit, like the terminology, like the vocab, the proximal intercessory prayer, like I mean, when I first read that, I was like, what the hell is that, right? Um, but they kind of try to parse this out so that you can distinguish different types of prayer. And basically, they broke it up into categories. So one type of prayer is, someone far away from you, like some dude somewhere in Asia could be praying for you and your well-being. You don't even know they're praying for you. That is called distal intercessory prayer. Someone distal or far from you, they're interceding on your behalf via prayer, okay? And then there's proximal intercessory prayer, which is someone else still praying for you, but they're adjacent to you, they're next to you. Like it could be a priest, it could be an imam, it could be a rabbi. Someone is guiding you in a prayer and doing it with you, for you. So that's really what this study looked at. And then obviously the most common type of prayer, which most people are familiar with, is personal prayer. Like I say a prayer for myself right now, or you say a prayer for yourself, right? So those are different types of prayers. And there's always this weird verbiage in these studies, but that's what the proximal intercessory prayer is. And that's what it was looking at. And specifically, it was looking at when someone like that, a spiritual guide, they didn't term him a priest or anything like that, but they did that prayer with the patient, the study participant. And it was specifically Christian prayer. And it involved, touch. Like you guide someone through prayer, touch is a part of it. Just like if you go to like a mass, for example, a Christian mass, there is touching when the worshipers go up to the altar. The priest will, do the sign of the cross or give them like Eucharist as an example. So it's not uncommon that prayer is more than just words and thoughts. There's also a touch ritualistic aspect to it. And that alone begs the question, how much of pain and anxiety decreasing is because of just human touch in a calm, controlled manner in this prayer room versus just someone sitting there by themselves listening to pre-recorded music. The patient population too, it was very skewed. It was a very low income population. It was like between $20,000 to $30,000 median household income, which is far lower than like population averages in the United States. And also, it wasn't representative of the total U.S. population at large. It was much more, I believe, Hispanic and Black population. So how generalizable are the study results? Um, who the hell knows? But I just more detail to break it down to make it a little more understandable, I think, is important because, like you said, Humayun, the clickbait and the catchphrases and reading just a headline or even just an abstract of a paper is very different than getting into the weeds of it and digging into like, oh, so that's how they did the study. Well, okay, now I'm a little less excited about the study.
Yeah. Yeah, I mean, the article would make you feel that there's some kind of divine intervention, right? That God came
Yeah.
and, ease the pain because prayer is much more stronger than music. But if you kind of look more into it, most of the studies that have been done with music, and there's a lot more data on music alleviating pain and improvement in pain scores and anxiety with music. And a lot of those are related to music therapy when there's a human in the room and actually doing music therapy, a guided therapy for patients, right? So is it truly the actual prayer or the music, or is it that human to human interaction? And I think that human touch in this age of AI is much more powerful than anything we can imagine, right? I mean, just a person sitting with you and praying for you has some very profound impact on your health and your well-being and your mental health, and your mental health and mental well-being can have a lot of effect on your pain score and anxiety, right? Knowing that there's someone there, kind of wishing well for you, sitting there with you, holding your hand, or kind of praying alongside you, can be very encouraging for a lot of people. Can be kind of very healing as well. I mean, there's something to say that, and right now the mechanism is unknown, right? Why did these people with prayer have had a decreased anxiety and pain score? We can't say that, and the only thing we can infer is it's that power of prayer, encouragement, and some hopefulness that comes along with prayer that cause that, right? So I think your mental health and mental well-being has a lot to do with it, and prayer obviously acts on that, right?
Yeah, no, it totally does. I mean, and like when I'm at the hospital, it's our hospital at St. Luke's. Obviously it's a religiously named hospital, but they have a chaplaincy service. So there's a chaplain in the pre-op area that comes and visits with every single patient before surgery if the patient chooses to. And the chaplain, he's Christian, but he's very agnostic to a patient's religion. He just does a very generic prayer with them for their well-being, for their family, to decrease anxiety. They go through the surgical episode well, come out with a good recovery. It's very, very nice, very simple, but oh, dude, like every patient loves that. Even a patient that is like, for sure, the opposite religion. I mean, I have a lot of Muslim patients, like women wearing hijabs. If they ask them, like, would you like the chaplain to come? Dude, everyone says yes. I have Jewish patients, atheists, Hindu patients. Everyone says yes, and everyone has a really positive experience with it. And the chaplain's great. I mean, I know him very well. I literally see him every day. And he's so polite. He's so kind. He's very respectful about boundaries. He's very aware of different religions and different cultures. He'll always ask, is it okay if I pray with you? Is it okay if I lead the prayer? Is it okay if I hold your hand? Would you like me to? But it's patients across the board are like, yes. And it's so relaxing to see that, right before I go into a surgery. Like, even though I'm not really partaking in the prayer, I sometimes just watch. I actually just feel really chilled out and relaxed and like a happy feeling. So I think there's something to it for sure, even if it's just people sharing an experience, or sharing like a hope, which is really what prayer is. A lot of prayer is hope. You're hoping for something good. You're asking for something good. You're yearning for that. I think that's a very positive thing.
Yeah, it's interesting. The chaplain Methodist West, the hospital that I go to, he's actually Muslim.
Oh,
And
really?
yeah, he's there's a Muslim chaplain, and he's actually going around and praying with people of all faiths, because I think the whole field of chaplaincy, or a chaplain, they're not. It's not a more of a it is more of a spiritual position, right? You're there for all
Yeah.
patients equally, and it's not specific to any faith. You're not bound to any faith. You don't have to do the Christian prayer. You don't have to do the Muslim prayer. You just have to do some kind of prayer where there's a divine being, divine intervention that's taking effect through that person and kind of helping you out mentally, right? And it's just a person that's there for the patients in difficult times, right? Especially when someone's about to pass away, they're transitioning to hospice, uh, they're towards the end of life. I mean, families love having chaplain, kind of just someone to talk to, and they have it's formal training program, right? I mean, they go through formal training how to help people with grief and
Yeah.
coping with such big losses in life, right? So I think prayer has a big role to play, and if a patient ever asks me to pray with them, I mean, I'm always agreeable. I don't think there's anything, wrong with, because as physicians, our role is there to be there for the patient, right? To be there for the patient, to help them in any way possible, and to act as a vessel of healing. If you're a religious person, a man of faith, you believe that the healing that comes through you. You're a vessel, and it comes through a higher being, and you're a conduit for healing towards the patient. And you can kind of consider that and be there for the patient. If they're a Christian, they're Muslim, they're Jewish, whatever their faith is, they're Hindu, you can partake in prayer with them. And I personally believe there's nothing wrong with that. My religion, my faith is not decreasing in any way if I pray with a Christian person or a Hindu person or a Muslim person or a Jewish person. That I'm just adding to their healing. And there's something to that as well, right? I mean, just because we're physician and we have personal faiths and personal beliefs doesn't mean at that moment when you're supposed to help someone, you can't be there for them.
Yeah, totally agree.
But
Yeah,
yeah,
it was interesting. I mean, I thought the main thing, it was just interesting that they were trying to draw parallels that, something that is experienced like a prayer or music can both lead to decrease in pain and anxiety. I think it's cool. What's funny is there's like so many different ways that people can address those issues of pain and anxiety in a patient, whether it's from a medical condition, an injury, a post-surgical patient. One thing was I think they did this at MD Anderson, I'm not positive though, so don't quote me on it, but they used like VR headsets, like the Oculus Rift thing, and it was linked to a video game. And when patients were undergoing a procedure, if they had the headset on, they were very immersed in the video and audio and the spatial environment of the headset, and had like a game controller or whatever, and they were like in this fake little area. They actually needed much less pain medication. They were much less anxious. I thought that was really cool study too. I mean, in a similar vein as this, I mean, they're basically just you're forcing someone to partake in an experience, and it kind of detaches them from experiencing pain when they're just like sitting there anticipating it.
yeah, yeah. That's interesting because there's been multiple studies like that where some kind of distraction and has some kind of distraction, something that kind of soothes you. Not, I think it was a game, but I think they've done studies where patients are just in a relaxing environment. Either during an MRI, they were wearing like a VR headset where they were able to kind of just watch a movie or observe or be in the ocean and kind of and they moved less. They had less anxiety. They didn't need medications. So there's a lot to say about the mental distractions we can create. And kind of like our second topic, there's a lot of discussions about psychedelics and magic mushrooms and psilocybin improving mental health as well, especially for patients who have treatment resistant depression or they have cancer, they're towards the end of life. Having some kind of a psychedelic experience has shown to have some improvement. There's some early studies, right? There's some early studies that have shown that there could be some improvement in their symptoms, their depression, their anxiety, when they're going through that kind of experience.
Yeah, and
Psilocybin.
that's what's interesting is like studying drugs like this. The studies are hard to do because all of these are classified as like Schedule 1 drugs, meaning at least per the drug schedule that they have allegedly no medicinal benefit and they're simply drugs of abuse. But obviously, more recently, a lot of these drugs like psilocybin, like we're about to talk about, ketamine has been a big one, especially microdosing of ketamine for treatment refractory depression and anxiety has real evidence, and the evidence has been growing. But also with that, there's a bunch of like ketamine clinics that have opened up that there's a potential for abuse too. Um, so I think it's very interesting. I mean, this is new stuff. People have anecdotally touted these psychedelics and going on a so-called trip, like a guided trip with a shaman or something that's common with DMT, ayahuasca, where people will do that and they will almost unanimously talk about how it's a life-altering experience. You got in touch with yourself, things that held you back in life or traumas from your youth, you were able to shed them and move on. So I mean, that many people say that much stuff in a positive way about something. I think there's got to be something to it.
Yeah, for a long time, these were studies. They were small studies with a small amount of populations, and there a lot of the subjective evidence that came out of those studies were very positive, right? But recently, when they moved on to larger studies, which were designed with certain doses and placebo controlled to somewhat whatever they could do, the results were less promising than what they thought before, right? So, in theory, psilocybin is a prodrug, which it is converted to psilocin, and that is a serotonin partial serotonin agonist. The SSRIs that are currently used to treat depression, they're selective serotonin receptor reuptake inhibitors, so that they allow for more serotonin to stay in our the synapses. But psilocin, which is a which it kind of comes from psilocybin, it just it's an activator of serotonin receptor, so works in a very similar way. So there is a case biochemically that it could possibly improve depression and anxiety symptoms, right? Now, a lot of people that went through those smaller studies and earlier phase studies, they went through a life-altering experience, and sometimes when you go through something like that, you tend to over-exaggerate your symptoms as well. I mean, sometimes there could be a crazy placebo effect where you go through something profound like a trip, which was probably a life-altering experience, and after that, the euphoria from that kind of continues to stay with you for a while, and you feel like your mental health is improved. How much of that was truly the experience where there was a human shaman, human involvement that kind of created that environment for you to improve those symptoms and kind of go through that guided tour of your or guided trip per se, right?
Yeah.
Versus if you just were in a room by yourself and you did something like that, would that be the same kind of effect in that, right? Just like we just talked about our first topic, the prayer, right? The prayer was a guided prayer with another person next to you, that human touch, the human in the room that's there guiding you and kind of going through this profound experience with you. That possibly had a lot to do with it as well. That whole experience rather than just the isolated psilocybin trip itself.
No, for sure. I think that's definitely the case. I mean, I think that's the case with anything, you share this experience and you come out after you do something very positive or very negative or somewhere in between, depending on the environment itself, who you're doing it with, right? Like, for example, you could go and walk in the park aimlessly by yourself. You could do it with a loved one. You could do it with your kid. You could do it with a friend you haven't seen in a long time, right? Those are very different experiences. The conversations you have, the things you see, what you stop at, what you comment on, and stuff like that. And it's basically you do the same walking path, but the experiences could be very different. With your son, who's a little kid, you might stop and throw some rocks in the water for like 30 minutes and not really talk about much. You're just enjoying doing that. Versus if you go with your wife, you may end up talking about a bunch of stuff, real life stuff, memories, plans for the future. You know what I mean? So like the same thing with drugs like this that are psychoactive. If you do it solo versus you're in college doing it with a bunch of buddies just goofing off, versus you do it in a very planned, methodical way with a so-called shaman who is an expert in leading people through these trips and through these substances to make sure you don't have a negative experience or a bad trip. In the same way, they can be very different. And I think that also makes it hard to study, right? Because if you as a study participant, in these trials are getting a set dose in a controlled environment, it's with a so-called guide. And how well versed is this guide in actual psychedelic experiences, that is in a clinical trial, versus is it just someone with a medical background who's making sure your blood pressure, your heart rate, your anxiety level, and all of those other vital signs remain at the normal thresholds, and you're not having some, psychoactive event. So those are two very different things, guiding someone through that and bringing them down or bringing them up if they're not having an appropriate experience versus just making sure they're medically okay.
Yeah, it's also very hard to kind of do a placebo control trial where there's no true placebo to a psychedelic trip, right? In a lot of studies that they did, they used niacin, which kind of causes a flushing kind of effect, or they used diphenhydramine, which is Benadryl,
Benadryl,
right?
yeah.
Or they use a 1 milligram dose versus a 25 milligram dose, a higher dose of psilocybin compared to a very micro dose
Yeah.
to compare, but it truly doesn't substitute for that that trip that you have, and
Yeah, they
it,
they didn't give him portobello mushrooms, that's for sure. No real placebo there.
yeah, and if you go through something like that, there's a big uh, kind of what I call like you feel like you need to feel better, and you feel like, oh yeah, I went through that, so I have to feel better, and you kind of have a self-fulfilling uh it's kind of like a self-fulfilling prophecy with, because when you go through something profound, you're forced to kind of make yourself feel like, yeah, there's something happened to me and I am better. And
Yeah, for sure.
how much truly is that the psilocybin itself that's improving your depression, or it's your mind telling you that you went through something like that, and then and, you're feeling better. But it's gonna be easier to monetize this, because there's a lot of people that would now, if this becomes, it shows even a little bit of data, and the government regulations slowly come off, as we've seen from the current administration at Joe Rogan's encouragement, that they're changing the regulations on these drugs. When it does become
Yeah.
more available, how many people will, with no real qualifications, and or very minimal qualifications, will try to get these licenses and open up like local clinics
Dude,
for
I can
free?
already see the headlines. New York Times. The number of mushroom farmers in America in 2027 has quadrupled. I wonder
Yeah.
why.
Yeah, so I mean, people will find ways to kind of monetize and sell, and even get people to use these substances maybe in an unsafe manner when it's not really indicated, right? And that's a lot already happening with a lot of other medications, like for example, testosterone therapy, right? It's just been a crazy rise in the amount of people that are going to these low T clinics. I know like 28-year-olds, 29-year-old, 30-year-olds that are going to these low T clinics per se, and getting shots of testosterone
Yeah.
every month.
Dude, I feel like
And
in Houston there's a low T clinic literally around every corner.
yeah.
They're
Yeah, I mean,
everywhere.
it's ridiculous, right? I mean, and a lot of people do not understand the downsides and the long-term effects of this, right? A 28-year-old going to a low T clinic, 31-year-old going to a low T clinic. Um, a lot of these clinics are their main business model is selling you that medication, the testosterone replacement therapy, to make profits. So when you go to them seeking care and asking them, hey, make this sound clinical judgment, do I need testosterone replacement therapy? They're never going to say no to you. They're not going to
Yeah,
say,
they're
no,
just
no.
incentivized to hook you on it.
Yeah, the whole incentive is to hook you on it, and the data clearly shows that not everyone is eligible for testosterone replacement therapy. There's a lot of evidence showing that testosterone replacement therapy needs to be done in an indicated manner, where you need to be examined by a physician, right? A physician who first goes through your history, and truly finds out what are the symptoms of low hypogonadism that you're having. Are you having extreme fatigue, sexual dysfunction, weight gain, body dysmorphism, things like that, and then based on those, just that's not enough. You need to get testosterone, you need to get your testosterone checked first, the levels of testosterone level checked, and not only once, you need to get it checked twice, and it has to be done um, before 9 a.m. When I get patients who are on these testosterone replacement therapy and they have a hematocrit of like 18, 19, and I asked them, hey, like, did you get your testosterone checked first? And they're like, yeah, I went in. And almost every time I ask them, did you go before 9 a.m. to get it checked? And almost always it's like, no, I just went in the middle of the day. And most clinics are not guiding their patients based on that, because your testosterone levels are best checked
Yeah, it
before 9
changes.
a.m. Yeah, there's a cycle. They go up as the early in the day, and then as the day goes on, it goes down. So if you get it checked in the afternoon, obviously testosterone levels will be low. So the real way to do it is you have to get a extensive history, and truly see if they have symptoms of hypogonadism or low testosterone levels. Then you're supposed to check the testosterone level twice at two different occasions before 9 a.m. And if the levels are below 300 twice before 9 a.m., along with the symptoms that they have, and you think those symptoms are related, then they may be eligible for testosterone replacement therapy. Otherwise, they're not. It's not truly indicated, right? And even if, when you do testosterone replacement therapy and the testosterone level is low, the first thing to do is to look for secondary causes of it, right? Is it obesity? Significant obesity, insulin resistance can cause secondary hypogonadism. And that's why you're supposed to check their FSH, follicle stimulating hormone, and luteinizing hormone levels, and you're supposed to check for prolactin and make sure there's no pituitary dysfunction as well, to make sure that it's not a secondary reason. Your pituitary is supposed to release hormones that instruct the testes to produce testosterone, right? So if that's not happening, if that cycle is broken, testosterone replacement is not truly indicated, because that's further going to suppress your pituitary function. You're also supposed to check your prostate-specific antigen, the PSA level, because there is a possible risk of causing prostate cancer by excessive testosterone replacement therapy. So there's a lot of things, a lot of nuances that go in there, and the number one side effect from testosterone replacement therapy, that it kills your sperm count and pretty much makes you infertile, right? I mean, a lot of these guys that are getting testosterone replacement in their early 30s, late 20s, mid 30s, they eventually want to have babies, and this could possibly be very harmful to those plans, right?
Yeah.
Uh, and a lot of these low T clinics are not counseling their patients in the right way, right? They may
Yeah,
have
it's
them
the
sign
same like
papers.
consumerism model, right? Like same thing, that the proliferation of these GLP-1 drugs, that every Tom, Dick, and Harry is just prescribing them left and right, expanding the indications to basically the indication is, do you want it or not? You know, I mean, that's happening everywhere, and it's converting a patient into just a subscription-based consumer. Because once you start a hormonal-based medication like testosterone, it's not just like you're correcting a lab value, like you go to the clinic, oh man, my calcium is high. Okay, I'll do X, Y, and Z. Now my calcium's fine. Okay. No, I mean, this is a thing you're on. You're cycling on. You need to have the appropriate dose. You need to have regular lab checks done, regular physical exams done. So it's now an annuity. That client, that patient becomes an annuity for these low T clinics. They're going to come in at set intervals. They're going to get X, Y, and Z tests. They're going to get X, Y, and Z labs. They're going to get the labs read. They charge cash only. So each time the patient comes in, it's cha-ching, cha-ching, cha-ching. They're going to make money off of them. And so every incentive, like you were alluding to earlier, is to get more people in the door, get more people to get on it rather than turn people away. I mean, as part of, as one of the studies in this testosterone thing, it looked at what was called the secret shopper, that they had this one guy go to 7 different direct-to-consumer models, these low-T cash-pay clinics. He went to 7 different clinics. 6 out of the 7 didn't even ask him about his medical history. Like, at all, didn't even ask him about his medical history. Didn't ask him if he's ever had any cardiac events, any family history of cardiac issues or anything like that. Didn't ask about his fertility history, plans on becoming a father or anything like that. They basically just showed up. They were like, "Oh, do you have fatigue? Oh, okay. Let's go send you for some labs." And then they were just ready to give him testosterone just like that. I mean, it's crazy, but that's literally how easy it is.
Yeah. A lot of the safety data around testosterone replacement therapy comes along the study called the Traverse study. The Traverse study it's a great study. I mean, it was done really well, and it was in patients who had either history of cardiovascular disease, or they were at high risk for cardiovascular disease, and they were studied, and the endpoint was MACE, like major adverse cardiovascular events. And at the end of the study, it showed that testosterone replacement therapy was pretty safe for patients with cardiovascular disease or high risk cardiovascular risk factors. So we know that testosterone replacement therapy is actually can be beneficial for a lot of patients, and it is safe to do in people who have heart disease. But that study was done in patients who were truly indicated for testosterone replacement therapy. These patients had hypogonadism, primary hypogonadism. They needed testosterone replacement therapy. They had all the symptoms. They had low T levels below 300, which were checked twice before 9 a.m. So it was done in the appropriate patient, and in those patients, it showed that the cardiovascular events were equal to people who were not taking testosterone. But most of the people, the study was not done in a 35-year-old with no real indication for testosterone replacement therapy. Their testosterone level may be 500 early in the morning, and when they check it at 2 p.m., it's maybe 200 now. And those patients getting testosterone replacement therapy, we don't know how risky that could be, and what kind of adverse events it could have, because we have not done those studies. We haven't done studies of testosterone replacement therapy in young, healthy individuals. and what that can do, right? We don't have those large scale studies to show that. And the government just recently removed that cardiovascular label from testosterone
Yeah,
replacement
the
therapy,
box warning, right?
the box warning based on the studies, but it added another warning that it may cause hypertension. Now, if the news headline that you're showing is that, oh yeah, there's no concern for heart disease with testosterone replacement therapy, and go ahead and do it, those getting unindicated testosterone therapy are not included in those trials. And those who don't have hypertension and in whom these drugs may cause hypertension are not included. They may have adverse cardiovascular events. So we have to be very careful in what is in the headlines and what truly the study says. And most people are not looking at that. They're listening to Joe Rogan. They're listening to all these guys that are promoting testosterone replacement therapy, but they are not closely looking at the studies where where it tells you the real data is in the right patient and not just in every Tom, Dick, and Harry.
Yeah, and I mean it, just one extra safety data point doesn't change the fact that there are real side effects and real issues that come from this all the time. I mean, in orthopedic surgery, we see patients, a highly disproportionate number of patients that get pec tears, biceps tears, triceps tears, Achilles tendon ruptures, all of these musculotendinous, these myotendinous injuries. Such a high percentage are in patients that are on high testosterone. I mean, it's almost like I would say in the last 4 years, pretty much 100% of the patients that I've treated with a pec rupture are men. No women, all men. And like maybe, I don't know, maybe 70, 80% of them are on some form of either testosterone, some steroid. I mean, I just ask them. Like, I just tell them, like, listen, don't bullshit me. Like, we're about to do a surgery together. You got to tell me straight up. Like, this isn't a joke. Are you taking something or not? And like they are, I mean, people are very honest when they're agreeing to go unconscious and let you cut them open. They'll tell you whatever. It's just crazy how many dudes are on this stuff,
Yeah.
and
Well, we have
it,
numbers, right? We have numbers. There's a PDMP data from 25 participating sites. It found that 439,659 more unique testosterone recipients in 2022 than in 2018, which is a 27% relative increase from 2018 to 2022, which is a huge amount of
it's a huge number in
that's a
just four
huge
years.
increase in just 4 years.
Yeah.
Um, the conventional increase from 2018 baseline is about 36%. It was a total of 36% increase from 2018 baseline till
Wow.
2022,
I
which
guess
was
COVID and all of the people sitting indoors listening to podcasts, they were like, "Yep, let's go get shot up with it."
yeah, yeah. I mean, after COVID, there was a big push. Oh yeah, like be healthy, take testosterone, take zinc, take your vitamins.
Yeah.
Do not take medications. And we've talked about this. There's a
Yeah.
distrust in mainstream medicine and what these scientific studies
Which is
show.
just like so stupid. I mean, I still just can't get over the fact that these idiots, like I think Joe Rogan has some interesting stuff, and I do like some of his stuff, but he was talking about it like when he had his ACL surgery. I brought this up before, but like he was like, yeah. So he was talking about his surgeon who did his surgery, who was a doctor, and obviously you trust this guy to cut your leg open and fix it. And then he's taught. I think it was a segment with Mark Zuckerberg, and he was talking about all these weird supplements to do to promote healing. And Zuckerberg was like, "Oh, I haven't heard of that, or my doctor didn't tell me that." And Rogan was like, right after
Well,
talking about how his surgeon did a great job, he's like, "Oh yeah, don't trust doctors; they don't know anything. You should be on this, this, and this." And I'm like, "What?
he's like, yeah,
You
just
trust
because
the guy to
doctors
cut your
cut
leg
you.
open, but not to take a stupid supplement? It's just ridiculous."
Yeah, I mean, but
It's
right,
so funny. I
some
mean,
some of the mistrust that we brought upon yourself by a lot of doctors just not really being showing the compassion or just thinking that, oh yeah, like kind of looking down upon patients over the years, especially during the COVID times. Oh, like, yeah, you're dumb, you're not wearing a mask, you're not getting the vaccine, like stop doing that, like kind of speaking down to patients. And that kind of pissed off a lot of people, and maybe that was a wrong attitude a lot of physicians in the scientific community took, right? This higher than thou attitude that for years doctors have had. So I can see why patients or people have had that mistrust. But the data doesn't lie, and scientific studies doesn't lie, the scientific process doesn't lie, and that's something we keep promoting through this podcast and for whoever few people that listen to us. We don't have such a big following as Joe Rogan does, or Andrew Huberman does. But what we can talk about is not a 25-person study in some obscure journal. We like to talk about studies with large human population that were randomized, controlled, and what the true data shows and what's practically doable for most people, right?
There it is.
Um,
Yep.
yeah. Speaking of Mark Zuckerberg, our last topic of the
Yeah,
day,
it's timely.
timely. Yeah, so it's interesting. I mean, you're talking about mental health and kind of having a human in the loop, right? We've talked about human in the loop during prayer, during psychedelic therapy, having the doctor being the trustful person that you can go to for testosterone replacement therapy. But Meta is also in kind of having a human in the loop when they're maybe monitoring younger adolescent individuals chats and looking for any signs of mental health or suicidal behavior, and they're sending alerts to parents that their kid could be in danger of something harmful to themselves, which is a very interesting idea in this day and age because um,
Yeah,
uh,
it's
you
like
know
a semi-controversial safety feature, I think, right? Like Instagram. So there's two different ones. So Instagram has its own thing, and then the Meta AI has its own thing. So Instagram will flag if it sees like a teenager who has a teen account on Instagram is searching suicide stuff, how to commit suicide, suicide related content. It'll send an alert to the child's parent because that's how the teen accounts work. It's linked to a parent. And then the Meta AI is if similarly, a teen is interacting with it, asking it questions, having a discourse with it relating to suicide, and it seems to get the gist that, oh shit, this kid may be suicidal, or they're contemplating it, they're depressed, whatever. It'll similarly, with a human in the loop, it won't automatically give a message to the parent. It'll get flagged for whatever characteristics they deem are risky for suicide, and it'll go to a human reviewer, and then if it's confirmed, and obviously it errs on the side of caution, it will send a message to the parent. But it raises big questions like, what the hell do you do now? You know what I mean? Like, obviously as the parent you should bring it up, but there's so many more questions that come up. I mean, what kind of home is the child in? Is it a single parent home, dual parent home? Is it a happy home? Is it a broken home? Is it an abusive home? Is the caregiver slash parent even going to care? Are they going to act in an angry way? Are they going to lash out? Are they going to punish the child rather than actually, connect and discuss it? Not everyone is able to have a discussion like that, right? Unfortunately, not all human beings can talk about things like potential suicide and all of that stuff in a mature way and in a
yeah.
way that's going to make someone want to share. So, I mean, I don't think it's necessarily a bad thing that there's this flagging process, but there's not really like a set pathway to go about it once it is so-called flagged.
Yeah, and it's a sensitive topic as well to discuss as well, and you got to be careful of what we say because a lot of people are going through a lot of mental health struggles, and but mental health is a huge issue, and we've talked about this in the past where people are using a lot of times Chat GPT, Claude, or Gemini as kind of like their counselors, as someone they're talking to on the side when they're mentally disturbed and they can't really talk to another human. Unfortunately, no one's using Meta's AI. Uh, you know,
Yeah, yeah.
so, but
Dude, when I read this, I didn't even know Meta had its own AI. I'm
yeah, they
like,
have the
nowadays, who the
Spark.
hell
Yeah,
doesn't have their own AI?
yeah, they have a Meta Spark they just released, and they're claiming it's going to be good eventually one day. But
But I
you know,
guess, if back in the day, in the AOL Instant Messenger days, if Smarter Child existed, I mean, everyone can have their own AI. Smarter
yeah,
Child was like the OG AI, dude.
yeah, yeah, yeah. But I think it's important because we've talked about this in the past, right? I mean, what if on Chat GPT someone is going in and kind of having these discussions, and the sycophant that Chat GPT can be, it kind of agrees with it and kind of gives starts giving it ideas, and it has led to some people committing suicide in the past. Now, is there a way to safeguard against that? And I think it's important to safeguard against that. It's safe, just like we're supposed to look through. And I think Meta is supposed to look through Facebook and Instagram for people who could possibly be planning some mass shootings as well, right? They've kind of flagged those as well. And it's mental health the same way. If someone is planning self harm, it should be flagged. Now, where does that leave privacy versus preventing something harmful like that. And I think uh, it also doesn't account for people who are maybe talk in a certain way or joke around sarcasm, or they're neurodivergent and they don't know how to express themselves properly, and they're talking. How many times will Meta raise false alarms to parents, and every time a kid says something odd online, parents get notified? Where will that leave a lot of these companies? And at what point it'll become like, cried wolf kind of situation where,
Yeah.
parents will keep getting alerts and they'll be like, okay, not this again.
Yeah, it's like
So that's
alert fatigue sets in and you just start ignoring the alerts. Kind of like an electronic health record. Like every patient chart you open, there's like
yeah,
15 alerts on
sepsis
exit,
alert.
exit.
Sepsis, like every patient has sepsis alert, and you're like, no, bro, they're not septic. Like, what do you
Yeah,
mean? This guy's here talking to me. So,
you're right.
so at what point the decision, the alert fatigue will set in, but possibly alerts could lead to a catastrophic. If they don't alert someone, it could be more catastrophic, where someone may commit suicide, and all the signs and symptoms were there online. So it's a hard discussion, hard topic to talk about, and I don't know how I feel about it. I mean, God forbid if my kid was contemplating something like that, having those thoughts, I want to know right away so I can intervene, and I trust myself to be there for them and intervene, and show them love and encouragement, and tell them I'm there, and seek out the right avenues for people who don't know. And calling 988 if you're struggling with mental health is the number to call in the U.S., or even 911. But 988 is a mental health uh, number to call. But I could do that, but not every adult in the household is a safe adult. And some of these softwares may alert the wrong adult, the parent that may not be the safe adult in the house, and that could be harmful as well for the kid. So
Yeah, and especially like, I mean, think about the reality that there's a lot of abuse. And what if a child, a teenager, is becoming suicidal and depressed because of their parents? And then those parents get that alert. I mean, they're going to be in that setting, maybe even less likely to try to help the child. I mean, I don't know. It's just to have an alert about something so serious without like an actual pathway. Um, I mean, maybe it absolves the company now from possible litigation, right? Because they've taken a step. They've sent the alert on to the responsible adult of this teen. But what then? I don't know.
yeah,
It just
I
seems
mean,
incomplete.
yeah, it's tough. So, but I think the key here is always keeping a human in the loop, not depending too much on AI, not depending too much on the robot, not depending too much on um, psychophants or people who are trying to sell you things that are obviously harmful for you, and having a trusted human in the room who you can trust, have a relationship with them. And the human touch, either being there in person, playing music to you, or praying with you, goes much further than any robot or AI software that's there for you. All right, bro. Till next time.